and try to build community. So if you have a camera and can turn it on, please do that and leave it on during the session. We would ask that you stay muted and not unmute yourself unless you're called on by one of the facilitators. And if you have any questions for Dr. Harkins or her presenters, please put them into the chat box and we'll try to get to as many questions as we can today. And we would ask that you not answer we would not answer the questions in the chat yourself unless you're one of the hub team members. And a couple of other things, we have a digital librarian, Kent Nursworthy, who is putting a lot of really great information into the chat during the session. And if you can link on those directly and get that information. And lastly, if you want more information about what's going on at Project ECHO regarding COVID-19, please go to our website and you can find recordings of previous sessions and a lot of other information there. So with that, I will turn it over to Dr. Michelle Harkins to introduce herself and move forward. Thanks, Michelle.
All right, thanks, Dr. Thornton. Good morning, and good morning before a holiday weekend. So it's good to see some faces, even though maybe no one's going anywhere for the holiday. I know I'm not, but that's okay. So thanks for joining us this morning. And I asked a colleague of mine to give a presentation today on diabetes. And the reason, you know, the Wuhan data suggested that the patients that had the worst outcome were those with cardiovascular disease and, you know, age over, 50, 60, 70, it went up per decade. But what we noticed in our cohort of patients, the majority of patients that did poorly were actually diabetics and in potential obese diabetics. So my question was, what is there something specific about diabetes that's putting these patients at risk, and is there something that we haven't really talked about or with this in particular? So it's my pleasure to introduce my colleague, Matt Bouchonville, who is an associate professor of medicine. He's an associate director for Project ECHO, so many of you may already know him, and he runs his own endocrine echo. And so I'm going to present a case of a patient that we got here, and then I'll let Dr. Bouchonville take over. So we'll have our slides. All right, next slide. So this is a 46-year-old woman who comes to the emergency department with dyspnea, subjective fever, chills, and cough that really have been worsening over the last week. On a review of symptoms, her cough is dry, it's not productive. She feels a little nausea, but has not had any emesis or abdominal pain. She has no polyuria, polydipsia. She feels a little lightheaded when she stands up, and this has all been happening over this week, and the symptoms have progressed during this week. Her brother also had a viral infection, and her past medical history is obesity, and she used to take medications, metformin for diabetes a couple years ago, but then she just stopped and thinks it's really just diet control, diabetes, but she also has not seen a primary care provider for over 2 years. She's not on any medications, and of course her family history is positive for diabetes in her father and her brother. Next slide. On the initial evaluation at the outside emergency department, her room air saturation was 86%. She was tachycardic at 110, had a normal blood pressure, and a little tachypneic at 22 with a respiratory rate. Her BMI was 34. In general, she appears very comfortable. She's tachycardic. She didn't have a murmur. Her chest was clear. Her abdomen was non-tender. She felt relatively well, just the symptoms had been ramping up over the week, so she decided to seek attention, and she had no lesions on her skin exam. Next slide. The initial labs at the outside institution, of course, her COVID swab was positive. Her sodium was 126, chloride of 90, potassium of 3.0, and a bicarb of 15. Her glucose was 400. She had an anion gap of 21. She had normal renal function, her troponin was negative, and her lactate was a little elevated at 3.4. Her white count was normal, and her chest x-ray had bilateral patchy opacities. Next slide. So she was given fluids and potassium and oxygen initially, and then she was transferred to our other facility at Sandoval Regional Medical Center, for mild DKA in the setting of a COVID pneumonia. When she actually arrived to SRMC, her bicarb normalized and her glucose was still elevated at 300, but her gap had closed. And so her gap was 8, but she still did have some ketones in her blood. Insulin sub-Q was started as a gap was closed, and she didn't have insulin started at the outside hospital because her potassium was 3, and they were a little worried that giving her insulin would shift more potassium in the cells and cause a bigger problem for her. So they concentrated on fluids, oxygen, and potassium at the outside institution. So she had the insulin sub-Q started. Her D-dimer on admission at SRMC was 308. LDH was 295, a little elevated, and a CRP was 11. Her hemoglobin A1C was 11%, and the estimated average glucose was 280 with that. Next slide. So she was treated with oxygen, she did self-proning, and she did really very well. She was started on remdesivir, and she ultimately was well controlled with only glargine 5 units at night and a sliding scale to control her blood sugar. They were anticipating discharge. She was on the floor of service, and then she spiked a fever and had worsening oxygen requirement on day 6. She was intubated on day 7 as she was requiring really high vent settings. They did a CT scan that did not reveal a PE, just had patchy bilateral infiltrates, typical with COVID. And then she was transferred to UNM Hospital prior to proning attempts there at SRMC because she was tenuous, and she thought, providers wondered, would she need ECMO? Instead of just trying to keep things going at the outside hospital. Next slide. So when she was over here, she had regular, typical vent settings. She was on volume control. We did targeted, tidal volume 6 cc's per kilo to try to decrease barotrauma. She ramped up on those settings. We paralyzed her, we've proned her. She's on INO, inhaled nitric oxide, as a pulmonary vasodilator to try to improve her oxygenation. She ultimately developed renal failure and is currently on continuous renal replacement therapy because she is on pressors now due to some of the sedation to maintain paralysis and proning, and so wouldn't tolerate regular hemodialysis. Ultimately, we've changed her to the APRV or bivent settings on hospital day 25. And this was just to try to improve her oxygenation. She never required ECMO, and we were able to do things over the course of time, but she is actually still presently in the hospital and very critically ill. Next slide. So with that, this is a case of a patient with what she thought was diet-controlled diabetes, otherwise no real medical problems, young woman who then comes in and does pretty well, and then in about a week into her course here at the hospital was probably a cytokine storm with a fever, a little hypotension, worsening respiratory status, and now is still quite ill in our system. And so we've seen this several times, and that's why I was hoping for Dr. Bouchonville to give us a talk about diabetes and what is it about diabetes that is making this such a risk factor for patients with COVID. So at that point, Dr. Bouchonville, I would welcome you. Thank you for presenting this morning, and we're excited to learn from you.
My pleasure. Thank you so much, Dr. Harkins. What a case. I'm going to go ahead and share my screen here so I can pull up my slides. And let's see. If your screen is like mine, you have a thing on the right with all the people's faces, and you can kind of minimize that so you can see the whole screen. Excuse me. So yeah, I'm Matt Bouchonville. I'm an endocrinologist or diabetes specialist, and I'm real excited to present this talk today. Is diabetes a risk factor for COVID-19? And let's see, advancing slide here. So no disclosures, and hopefully by the end of this talk, we'll be able to recognize that diabetes is a risk factor for complications of COVID-19 infection. And we'll be able to understand some of the potential mechanisms for increased COVID-19 risk in patients with diabetes. It's not fully fully understood, but there are a lot of possibilities that have been studied, and we're going to review that here. So this is I'm going to start with this nice summary report, and if you have a copy of the slides, the last slide is the references, so you can find this this publication from the ADA that was just published this month in Diabetes Care. But it's a nice summary of the early reports, mostly out of China, about the risk of complications of COVID-19 in people with diabetes. And so long story short is that thus far, there has not really been any evidence showing that people with diabetes are at a higher risk of getting COVID-19. So if you have diabetes, your risk of getting COVID-19 doesn't appear to be any different than people without diabetes. At least there hasn't been any strong data to suggest that yet. But for people with diabetes who get COVID-19, there's strong evidence that the risk for complications of COVID-19 is much higher. So maybe not a higher risk of getting COVID-19, but definitely a higher risk of complications. And based on early reports from China, it appears that glycemic control might play a role in the severity of the illness. And I'll share with you some data that supports that, as well as some data to suggest that it's more complicated than that there might be other things at play responsible for the increased risk we're seeing in people with diabetes. And so, again, this was really based on early reports from China. If we look at data from the United States, we can see that there's definitely been a signal there as well. This was a publication from the New England Journal of Medicine recently. This was a case series in the Seattle region of critically ill patients with COVID-19. Just a small number of patients, 24 patients across 9 Seattle area hospitals, and average age was 64. But what was really striking is that the most common coexisting disorder was diabetes. Almost 60% of this cohort were patients with diabetes. And that's a much higher prevalence, 60% of, well, of course, higher than the prevalence we see in the United States, but also looking at case series of how prevalent is diabetes in the hospital setting, this is much higher than that. So it suggested that there's something to having diabetes where they're at higher risk of having complications. A larger series that was more recently published in the New England Journal of Medicine in May, this was a preliminary report of remdesivir for the treatment of COVID-19. Again, larger series, 1,000 patients enrolled in this trial. And here again, type 2 diabetes was very prevalent in that cohort. Same with hypertension and obesity, so kind of a metabolic syndrome profile for these patients who are more ill, hospitalized with COVID-19. And then an even larger series published recently in JAMA, so this was almost 6,000 patients. These were people hospitalized with COVID-19 in New York City. And similar median age, 63 years, but same kind of pattern, hypertension, obesity, diabetes, seen with high prevalence in this cohort. So again, these data aren't necessarily showing that people with diabetes are at a higher risk of getting COVID-19, but it does suggest that people with diabetes who get COVID-19 they're representing a high prevalence of people in the hospital that are sicker with COVID-19. So how can we quantify the increased risk that we're seeing in patients with diabetes? And there was recently a preliminary report that came out of the UK. This was looking at the National Health System database. So they have over 60 million individuals registered in that database. And of that 60 million, 0.4% of those have type 1, which is autoimmune diabetes, and almost 5% have type 2 diabetes, the one we associate with insulin resistance, like the case we just heard today. And of this database, there were over 20,000 COVID-19 related deaths. Interestingly, a third of those occurred in patients with diabetes. A very alarming statistic there just by itself. If we look at the odds of death from COVID-19, the odds ratio of mortality, you can see that compared to patients without diabetes, the risk of dying was much higher, 3.5 times more likely to experience mortality related to COVID-19 in a patient with type 1 diabetes. The risk was also increased in type 2 diabetes with an odds ratio of 2, so 2 times more likely to die of COVID-19. So this report not only demonstrates that there's a higher risk of death specifically in this study, but also that the risk might even be higher in patients with type 1 versus type 2 diabetes. So those with autoimmune diabetes, the risk appears to be almost double that of those with type 2 diabetes. And then again, both of them are at much higher risk compared to those without diabetes. Interestingly, this was a very age-dependent finding. So this is the same series here. And you can see the risk of mortality. So the red line here represents type 1 diabetes. The blue line represents the cohort with type 2 diabetes, and then the black line is the general population. And kind of mirroring what we see in the general population, where the risk of mortality increases with age, especially once you get up into the 60s, 70s, and 80 plus, but higher with type 1 and type 2 diabetes. Below the age of 40 or so, it's the risk of mortality is much lower, even in those with diabetes. So higher risk in those with diabetes of mortality and strongly age dependent. All right, so I alluded to the impact of glycemic control earlier. So how does glycemic control impact survival in patients with diabetes? And this was a recent report in the Journal of Cell Metabolism that it was a retrospective study of over 7,000 COVID-19 patients. And diabetes status, again, was associated with a higher risk of death. But they took that further and looked at the impact of blood sugar control. And what they found, this is in millimolar here, but that's the same, 10 millimolar is the same as 180 milligrams per deciliter, which is what we typically use to measure glucose in the States. And what they found is that for those with blood sugars on average of less than 180, which we would consider well controlled in this study, that was considered well controlled, survival was much better, 98.9%. Whereas those with blood sugars greater than 180 on average, these hospitalized patients, the risk of death was much higher. Survival was only 89%, so 11% death rate. This is interesting. It doesn't prove causality because it could be that the blood sugars are high just because these are sicker patients with COVID-19. Or another possibility is that the high blood sugars are increasing the risk of complications of COVID-19. So we don't really know from this, but there's certainly a relationship there. But again, there's some interest lately in other mechanisms playing a role in the increased risk of complications we're seeing in patients with diabetes. And so why do people outside of hyperglycemia, are there any other reasons why people with diabetes might have a higher complication rate, those with COVID-19? And so there's been a lot of interest lately in the potential role for the renin-angiotensin system. And one thing we know, at least in mouse models of diabetes, so I mean, this could be the same case in humans where it's not completely known yet, but ACE expression, so angiotensin converting enzyme, is higher in the lungs of mouse models of diabetes. So it might be that that's the case in humans with diabetes as well. And activation of ACE, so ACE expression, is associated with inflammation. It's associated with vasoconstriction. That's why ACE inhibitors tend to lower blood pressure. But also associated with thrombosis, lung injury, fibrosis, edema, all the things that kind of lead to what we see in COVID-19 is devastating complications of people with the infection. So there might be higher ACE expression in the lungs of people with diabetes. And ACE2 might also play an important role in the disease process. We know that ACE2 is a target of cell entry. And I've got a schematic coming up, a figure that illustrates that. And but ACE2 might also play a role in kind of moderating ACE expression in people who have COVID-19 infection. So ACE2 is a counter-regulatory enzyme that is kind of doing the opposite of everything that ACE I just showed you was doing. So decreased inflammation rather than increased inflammation. And that's through suppression of TNF alpha and some other mechanisms as well. Anti-fibrotic effects, vasodilation rather than vasoconstriction. And there's some evidence to suggest that ACE2 might actually play a protective role in those with infection. But the current thinking right now is that outcomes might have a lot to do with the relative balance of ACE and ACE2. So again, ACE2 being more protective, even though it is a target for cell entry, playing a protective role in the setting of COVID-19 expression. And again, ACE playing more of a detrimental role for the reasons I just outlined. And so typically what happens, whether a patient has diabetes or not, hopefully you can see my little mouse pointer here, my trackpad pointer. So the virus binds with ACE2 on the epithelial cell of the lung, and this leads to cell entry, viral entry, replication, and ACE2 is actually downregulated, so that your ACE to ACE2 ratio becomes less favorable. ACE is still there, but less ACE2, so it kind of tips the balance and leads to an increased risk of lung injury. Now, in patients with diabetes, if it's true that humans with diabetes, just like the mouse model, that they have increased ACE expression in the lung, then this is kind of a double whammy picture. They have an even worse ACE to ACE2 ratio, leading to increased lung injury and so forth. I want to highlight, though, that if we think about ACE inhibitors and angiotensin receptor blockers and what they do to ACE expression, this raises a very interesting question. So does this potential mechanism for increased COVID-19 severity and those with diabetes, does this carry any therapeutic implications? And I'm going to highlight this recent study from Lancet, where they looked at the use of ACEs and ARBs, ACE inhibitors and angiotensin receptor blockers, and the risk of admission or death from COVID-19. This was a case population study. So they identified 1,100 COVID positive cases requiring admission to the hospital. And then they matched COVID positive population controls that weren't hospitalized in a 1-to-10 ratio there. And they looked at the impact of ACE inhibitors and ARBs versus other antihypertensive medications on hospital admission in COVID-19 patients. And what they concluded is that it appears that ACEs and ARBs, because this has been a controversial question, right? If ACE2 is a target for cell entry for coronavirus, do we need to worry about ACE inhibitors and ARBs if they might, some studies suggest, increase ACE2 expression? Is this going to lead to more people having COVID-19 infections and so forth? But they actually concluded that ACEs and ARBs appear to be safe. They did not increase the risk of hospitalization anyway. This study was not able to tell or answer the question of whether maybe milder infections are seen with higher rates, but at least it didn't appear that ACEs and ARBs were increasing the risk for hospitalization. And this included fatal cases or those managed in the ICU. But what was really interesting, also very interesting, is that they looked at potential interactions here. So if you're not familiar, this is a forest plot. We've got the line of unity here, and then we have confidence intervals that are, as you can see here, are typically crossing the line. What you're looking for, and when we're looking at interactions here, we're looking to see whether there was any differential effect of using ACEs and ARBs when you kind of broke down this cohort into different subgroups based on sex, are they female or male, based on age, hypertension, and so forth. And then you see, was there any difference in these confidence intervals between groups? And if so, you would see a p-value of less than 0.05. And actually, the one area where they did see a significant difference with a p-value of 0.004 was the absence or presence of diabetes. And very interesting here, if you look at the confidence interval for people with diabetes versus those without, it actually falls to the left completely of the line of unity. There was actually a protective effect in patients with diabetes who were on ACEs and ARBs. They were about, and we can look at the odds ratio here, it's about 0.5. So they were about 50% as likely to be hospitalized or have a fatality or be managed in the ICU with COVID-19 compared to those without diabetes who were on ACEs or ARBs. So very interesting, and it just speaks to the potential relevance of the renin-angiotensin system in patients with diabetes specifically, because again, there didn't appear to be any impact in patients in patients as a whole. So there might be something to that. One last slide I wanted to just throw in for fun, because it's actually not even published yet, but it's in circulation. It hasn't been peer reviewed yet, but it also might shed some light on, again, the mechanisms for worse outcomes in patients with diabetes who have COVID-19 infection. And so metformin, this was an observational study of metformin and risk of mortality in people that were hospitalized with COVID-19. And these were people with obesity and with diabetes. And we know that metformin reduces TNF alpha, which of course plays a big role in inflammation. So it could play a role in cytokine storm and so forth. And we know that metformin suppresses TNF alpha, and it appears to be a more prominent effect of metformin in women rather than men. So this was a retrospective analysis of claims data from over 6,000 hospitalized COVID-19 patients. The average age was 75. And they found that those on metformin who were women, that mortality was actually decreased by over 20%. So an interesting finding, and it definitely needs to be confirmed with other studies. But just to kind of summarize everything I've shared with you, again, we don't have evidence yet to suggest that people with diabetes are at a higher risk of getting COVID-19, but for sure diabetes is associated with higher complications of COVID-19 infection, and this includes death. And we talked about the relative increase in risk, whether your patient has type 1 versus type 2 diabetes, and that it appears to be very age dependent. In terms of the mechanism for increased risk in COVID-19 infected patients with diabetes, it's likely multifactorial. We talked about a potential role for hyperglycemia, and we talked about a potential role for patterns of ACE expression leading to increased likelihood of inflammation, thrombosis, edema, and lung injury. So I think, and here's some references, and I think I'm happy, or I know I'm happy to take any questions. I'm going to stop sharing my screen here so we can all see each other. All right.
Thanks, Matt. That was excellent. Kind of trying to help me put my head around diabetes, and what are the issues that are the why is this woman that I presented getting well, going to go home, and then now still has a severe complication. And I don't know how many really present in DKA, but she had mild DKA that very quickly resolved with fluids, and maybe the COVID tipped her into DKA, or a little of each. So it's interesting. But I'll let Dr. Thornton ask the chat questions.
Thank you, Michelle. Thanks, Matt. That was a really, really excellent presentation. There's a couple of questions in the chat, one related to the case presentation. Carlos Nolasco asked, do you think her risk was more increased due to obesity rather than diabetes?
That's a great question. And I'll let Matt answer too, because I was wondering, because I've seen a few that have just had obesity. We have a 33-year-old obese gentleman, 56 BMI on ECMO, who didn't have diabetes. And we had a 23-year-old admitted that didn't have diabetes. He was just a little portly, not much, but he, 23. So I think the diabetes is a risk factor for some, but I think obesity really adds into that. And I don't know, Matt, if you have any other comments on that.
Yeah, I agree with you, Michelle. It's a great question too. There's definitely something there, that there's a signal that people with obesity, independent of diabetes, are also at increased risk. How much of that is in people with diabetes, the worst outcomes, how much of that is from obesity versus the diabetes? I haven't seen any reports that are able to parse that out. As a whole, those with type 1 diabetes are leaner than those with type 2 diabetes, but there's definitely still at least in one series in the US, 30% of those with type 1 diabetes are still overweight or obese. But I bring that up because lots of lean people with diabetes are having that poor outcomes as well. In fact, I showed you some data from the UK where the type 1 diabetes outcomes were even worse than those with type 2 diabetes. So likely they're both increased risk factors, diabetes as independent of obesity as well. I'm not sure about ACE expression in the lungs in those with obesity but no diabetes. That would be interesting to see if there's a shared mechanism potentially.
Yeah, I think in an obese patient, all of the adipocytes, they're considered inflammatory. You know, you have an extra adipokines, and I believe you have more, you know, you have ACE receptors in the adipocytes, I believe. And so if you've got more of those, you have more ACE receptors. So maybe there's a pathway there. And I think there's also a concern on the obese patient that comes into the ICU, you know, trying to oxygenate them. If they have a lot of abdominal obesity, it can also cause a little compression or inability to expand just in regular breathing. And so we may have issues with them trying to oxygenate them. It may be a little bit more difficult, and it's extra work for them if they have obese chest or abdominal contents that kind of rise up. But I think there's the obese patient is considered to have increased inflammation, which may be why they're also, you know, MIs, OSA, they're at risk for PE. You know, there are a variety of things that just obesity in and of itself can do. And I think there's more ACE expression potentially. So separating out the diabetes and the obese question are difficult, but we do see it here where it's just obesity as the risk factor for poor outcome.
Thank you, Michelle. Matt, can you talk about a little bit more about ACE inhibitors? And the question was, do ACE inhibitors lower ACE1 or ACE2 or both?
All right, thank you. Yeah, it's so they are going to counter ACE expression. And so that, at least in patients with diabetes, might be what is improving or was shown to improve in this one series I shared with you, outcomes in those with diabetes who also had COVID-19. The impact on ACE2 is not quite as clear. There's some mixed findings on that, but most of the evidence I've seen suggests that they're actually increasing ACE2 expression, which is why early on there was some concern about, wow, are ACE inhibitors actually increasing the risk of COVID-19 infection? Well, in theory, if you're increasing ACE2 expression, there are going to be more targets for COVID-19, but actually that increased ACE2 expression in the setting of blocking ACE expression, if anything, in patients with diabetes, it's actually improving outcomes. But again, we can't, these studies don't prove causality, but at least in those with diabetes, that was the association. As a whole, there was no impact on disease severity. But again, it was really the subset of those with diabetes where it appeared that ACEs and ARBs might actually be protective.
Thank you, Matt. Carlos Nolasco, I'd love for you to unmute yourself and actually ask your question, your next question, just as it's a very interesting and relevant question.
Sure, yes. So I was taking health and economic disparities out of the discussion just because, you know, that plays a role in adverse clinical outcomes. I wanted to ask if there's any data suggesting that Hispanics or being of Hispanic race may be associated with a higher risk of hospitalization or worse outcomes due to the increased risk for metabolic syndrome or the risk of diabetes that we know that Hispanics have.
Thank you, Carlos. Can you just also introduce yourself, where you're from?
Yes, so hello. Sorry, I'm doing some dishes here. I'm from El Salvador. I'm a practice internist here in Springfield, Illinois. I'm doing private practice right now, but for 5 years I was an academic internist at Southern Illinois University, and I used to be part of Project ECHO, hypertension with the university from 2017 to 2019. And right now I'm trying to figure out if we can open a Project Echo on COVID-19 for Salvadoran physicians too.
Excellent. Thank you so much.
My pleasure.
Over to you, Matt.
All right, thank you. That's an excellent question, Carlos, and nice to meet you.
Same.
In the United States, there's certainly evidence suggesting ethnic disparities in terms of complications and death rates related to COVID-19. I'm most familiar with that data with respect to Black Americans. I am not positive, but I mean, I could make a guess that yes, maybe we're seeing the same thing in Hispanic Americans, but I haven't reviewed that closely. But any group where there is a higher prevalence of obesity and diabetes, again, we don't have strong evidence that they're at higher risk of getting COVID-19, but certainly the risk of complications appears to be higher.
Yeah, and I would say the majority of our patients admitted to UNM hospital or even our Sandoval Regional Medical Center have been, Native American or Alaska Native with a lot of have diabetes, obesity, and all those things. So, that's the majority of the patients that are admitted to our institution, but that also is, we're right neighboring to the Navajo Nation, and we have several Pueblo tribes here in New Mexico. So we're seeing a large proportion of our patients are Native Americans. And the other, obviously, we're in a majority-minority state, and so we have a lot of Hispanic patients as well. And those seem to be the predominant ones that are admitted to the hospital, or at least in the ICU from my standpoint. So it would make sense.
Thank you, Michelle. So that is the last question in the chat. We would love to hear if anybody has any questions related to this, or I think anything else, Michelle, you'd be happy to hear them. So any other thoughts, Michelle or Matt?
I just kind of getting back to the case, I don't know, Michelle, whether it's been protocol here for critically ill patients to receive dexamethasone, given some recent data, but just another consideration in patients with diabetes because of the balance between the dexamethasone and the higher blood sugars. So often if that's the case, it's recommended to treat patients with an insulin drip, but I wonder how this patient is doing from a glycemic standpoint now.
So this patient was given dexamethasone later, especially when the recovery trial was published, suggesting less mortality if you were on a ventilator, getting dexamethasone. So then, yes, was put on an insulin drip because you really have to kind of watch how their glycemic control is impacted when you're putting people on steroids. And I think because of that trial, whether that trial has the most sound data, and the randomization scheme was a little off, but people are using it. And so that's another thing that you need to really be kind of on top of to control their glycemic issues. We've had 2 or 3 other patients that in our ICU, and Matt, maybe you can help me with this too, that have had extreme hyperglycemia just randomly. And that is reported that with COVID, you may have issues with hyperglycemia. And all of a sudden, for no reason, they didn't get steroids. All of a sudden, they're on an insulin drip at 8 or 10 units an hour. And then in a 24-hour period, it just seemed to resolve. And we didn't have a reason for that per se. And I don't know what mechanism there may be for that. And maybe it was just someone was giving them something we didn't know. But I doubt that in the ICU.
That is really interesting. Yeah, and these were people with pre-existing diabetes, but some labile blood sugars in the ICU.
Right, just everything was fine, and then one day they just spiked up, and that's maybe part of the storm, having more hyperglycemia, just all the metabolic disturbances. So it was surprising, but and they had a fever, and it was more difficult to control their blood sugar. And then, more aggressive insulin drip, and then we're able to bring things down, and now they're back to their normal state, just with sub-Q. It was interesting.
Wow. Yeah, that would add a major challenge to treating these patients. At least anecdotally, Stanford University runs the nationwide diabetes in the time of COVID echo on Wednesday mornings, and I've heard them describe patients with just very labile from hour to hour glycemic control that's presumably related to just what you mentioned, Michelle, changes in cytokine levels and inflammation, such that it could be really risky to treat those patients with subcutaneous insulin because their insulin needs can change from hour to hour. So again, just speaking to the importance of considering IV insulin in the ICU setting.
Yeah, thank you.
Patients.
Thanks.
Thank you very much. There's a couple other questions that came up in the chat. Catherine Torres asked, do these patients need to see endocrinology and cardiology outpatient once they are discharged? And I'm sure, Catherine, I don't know if you want to unmute yourself. Maybe, are you asking about patients in general or just patients who already have diagnosed diabetes?
No, I have received my first patient that survived. I'm a medical director at St. Michael's Clinic, which is a nonprofit clinic that sits within the Navajo Nation that's not associated with IHS. And so what I want to do is present him in one of your echoes, because he did survive. He lost 50 pounds. He was ventilated. His hemoglobin A1C was quite high, and he was obese, and he's lost the weight. But now he, was discharged a few weeks ago, and I've been following him, and he's starting to put his weight back on. And then, I'm trying to get him to cardiology, but there's no evidence now to help those of us out in primary care. Now that they've survived, how do we, one, keep them healthy, and what things do we need to do for them? So for me is that, do I need to just consult endocrinology? Because he was able to go just staying on the oral hypoglycemics, and he got off his insulin. So if I can keep him with his hemoglobin A1C below 7, it will be nice. But kind of what are the things I need to be looking for? So, and it's impressive to see him. He's like so full of joy, he really was going to walk out of that hospital, and he was fortunate enough to be able to go to rehab after his experience. So they were really able to get him to walk and do all those things. And it's a joy to see him, but I want to make sure we're following him correctly. And for me, because IHS doesn't have any outpatient facilities open, I'm going to start seeing some of those people as they transition out. But there's really no follow-up. Like, what do I need to be doing to make sure, So I'll be glad to present him, which Dr. Thornton, I'll talk to you about that later this week. But just kind of your thoughts. I kind of want to hear what everybody thinks about that.
Yeah, I'm happy to.
Great question, Catherine. Go ahead, Matt.
From an endocrine standpoint, I think it's the things to watch for with somebody who's experienced 50 pounds of weight loss. I think are going to be hypoglycemia. I'm sure if he was on insulin before, his requirements are probably much lower now. And I think you bring up a really important question, because with people with diabetes representing such a large segment of the critical care population, we're going to be seeing this more and more. In New Mexico, at the University of New Mexico, we're always happy to help with diabetes control, but travel right now is tricky with COVID-19. And I think that what you brought up, presenting this patient on the network, is a great idea. I'm going to put our digital librarian on the spot here and request that he put in the chat box, if he hasn't already, a link to our Endo Echo on Wednesdays, and then also the Diabetes in the Time of COVID Echo, which is also free to join the National Stanford Echo, which is also on Wednesdays. So you can click on that and register. Does that answer your question, Catherine?
No, thank you. Yeah, because I think it's something we, really have to, I'm glad that we're going to start looking at it together, because it's amazing to do really the hard work everyone has done and how fast all of you in critical care have really pinpoint what's really going on. But now they're surviving, and so now how to make sure we continue to keep them in good health. So I appreciate that. Thank you.
Sure.
Yeah, and
go ahead, Michelle.
I was just going to say, that's been a topic that's come up as a request potentially. What do we do with the survivors, or who survives, and what do we look for? And our Alicia Parada does our COVID follow-up clinic, and I see some of my study patients in that clinic as a follow-up once they've gotten out of their Act 2 study. And you know, what things do we need to look for? So that's a good topic to kind of put together in a nutshell for folks. Now that patients are surviving and back into their community, what things are important to follow up? So that's a good topic that we can address in a few weeks.
No, well, and thank you, because not all of them are at UNM. So as you know,
Correct.
they've been flown all over and then they just get sent back.
Correct.
And so, and UNM's done a good job about making sure there's follow-up. So for those patients, it's nice to hear that you're here and available for that. Thank you.
Great. Thank you so much, Catherine.
Now,
Did you have something else to say about that?
Yeah, and I know this isn't your question, Catherine, but just a nice general tip for people on the network right now is that we're seeing increased use in recent years of SGLT2 inhibitors because of emerging evidence that they're cardio and renoprotective. And so we're thinking about that class of medications in older patients with heart disease, especially. And this is a group of patients at increased risk for COVID. That class of medications is associated with an increased risk of DKA. So most people are recommending holding in your outpatients with diabetes, if they do contract COVID-19, considering stopping or holding the SGLT2 inhibitor until they've recovered to help lessen the risk of DKA.
Thank you, Matt. There was another question about, will the association between ACE2 and the outcomes of COVID-19 support giving non-diabetic patients with COVID-19 ACE inhibitors?
Great, thank you. And right now, the recommendation, because there's evidence in people, including those with diabetes, that ACEs and ARBs don't increase the risk of complications. There didn't really appear to be a protective effect overall either. So the recommendation is to just continue ACEs and ARBs for right now in the absence of a contraindication. I've not seen any suggestion for putting patients on an ACE or an ARB in the absence of hypertension or diabetes. And again, in those with diabetes, it appeared that they had a protective effect in terms of hospitalization and mortality, but there is no recommendation right now to put people on diabetes on an ACE or an ARB in the absence of albuminuria or hypertension.
And there is a trial that is, you know, because a lot of things we don't know the answer to. And so really the way to find an answer is with a clinical trial and a kind of a rigorous way of doing things. And so we are potentially going to start the RAMIC trial here, which is giving an ACE inhibitor for treatment of COVID in probably the non-hospitalized patient to see, does that worsen or does that help prevent the admission rate. And so that's one of the things that we're kind of looking at now is so it's giving an ACE inhibitor to treat COVID, and it's the RAMIC trial, and it's on clinicaltrials.gov. But we haven't signed up yet, but that's one of the things we're working through that process to get that trial going here.
Thank you so much, Michelle. I just wanted to let everybody know that the CME link was put into the chat a couple of minutes ago, and if we would love to get your feedback and hear about things like this that are coming up that you would like for us to present on, and if you'd like to present a case, please let us know that as well. I also want to thank Elsie Benitez Vargas, who's working with us here at Project ECHO on some Latin American ECHOs, Spanish speaking, and they're just getting started, and for, I think for Carlos, if you're interested, please contact us. And for anyone else who's Spanish speaking, there are, again, Latin American COVID-19 echoes in Spanish now on Monday mornings at 9 o'clock Mountain Time.
Thank you.
You're welcome. So there's no other questions, Michelle. I don't know if you want to, I'll turn it back over to you.
Yeah, so again, thanks so much, Matt. That was really excellent, and kind of the pathophysiology and with ACE inhibitors and diabetes, and knowing that these patients are at a risk of extreme complications, even though you think they have very mild disease, it's possible. So I do appreciate your time this morning and talking with us. Thank you so much.
Oh, thank you all. Appreciate the opportunity.
And so for the next sessions, we have next week, Dr. Elena Zamora will be presenting on mechanical ventilation and timing of intubation, trachs, and other airway management. We may model the C-long helmets for CPAP, and some questions had come up about that over the course of time. But just kind of where we are now with our, when do we intubate, when do we trach, are there other specific vent manipulations or other things that we can try to help the patients from our months of experience now. And then we will also be having hopefully a pediatric update on pediatric disease and the multi-inflammatory system disease that they have. And then potentially an update on coagulation parameters, platelet therapy, and other things with our database here. And are we doing the right thing and pooling the data and following up with what other institutions are doing? So those are kind of the next topics up on the docket. But I do also, I've had some folks ask about the recovery phase. And I think that would be an important topic just as the patients come back into your community. These patients some have had severe ARDS on a trach, on a vent for weeks. So, what does that look like? And how is that gonna go back into your community, and how are you gonna take care of these patients? So they also may have PTSD, they may have, other things from their long ICU stay and sedation and issues and critical illness, polyneuropathy from all of the medications. So a lot of things that we can talk about in the future. So, all right. Well, if there's no other questions, thank you so much, and happy 4th. And I hope you enjoy your weekend, and we'll look forward to seeing you next week.
Thanks, everyone.
Bye.
Bye-bye.
So,
yeah, I think the follow-up is it's a great idea. I don't know that there's a lot to say. People don't really know.
There are some data about, ARDS survivors in general, ARDS COVID survivors. I think there are racial disparities in that as well. And I think, it's just going to be, we don't know a lot right now, but I mean, there are some things coming out about what these folks are up against.
Yeah, and maybe we can find it. I don't know who a good speaker would be on the health disparities issue. It's just, it's more and more data is becoming available, but I don't know. Yeah, we should think about that.
Yeah.
Should that be put as like a potential topic then for August the 6th?
Sure. Yeah, I'll think about it too, Michelle. I don't know who's the right person that I know of anybody, but
yeah, I mean, I know Alicia, I thought about asking Alicia Parada just to talk about her clinic, the follow-up clinic, and what they are looking at and what they're seeing and telling patients. But, you know, she could be like a person just to present that little bit. I don't know that she's really the right person to talk about the disparities. Let me think about it.
Yeah, maybe it's a separate. I think it's a separate topic of its own. Yeah. But I'll think about it too, because I've been reading some of the literature, but just to see if there's somebody even nationally that might be interested in just giving a brief presentation. I'll think about it too.
There was on our division director forum, Gabe, is it Copeland? I'll have to think what his last name is, and he might have been from Hopkins, but he was just talking about racial disparities. You know, we're just talking about the whole aspect of what's going on in the world now, and then all the racial disparities in medicine, period. And, you know, and then, you know, a little section on what has been seen so far. So I'll try to find his slides. But he was a pretty good speaker. So anyway.
Yeah, awesome.
Maybe I don't know if you know Catherine Torres, Carla.
I don't know her. Michelle, do
you
you?
mentioned her name that she was going to email you, so I was like,
oh, I think she meant maybe she'll email the COVID.
Okay. Yeah, I'll keep an eye out for that and stuff. And then if so, then maybe she would want to present a case for the post-COVID recovery when
Yeah,
Alicia
absolutely.
Potter if she's able to be the speaker as well. Okay, great. Well, thanks. And I hope everyone has a wonderful holiday weekend.
All right, you too.
All right, you too. Sounds good. Bye.
Bye.
Okay. Yeah, it seemed like an interesting, I think it was a little lower attendance than I thought it was going to be, but then it may be because of the holiday. So we'll see over the next couple weeks and how that goes. I feel like, I wonder how much critical care is going to creep out of just critical care now that the multi-specialty one is gone. I feel like those two topics are a little bit going, but you know, if there's the need and stuff, so it sounds good. And any feedback on your side, Kent, before you leave?
Everything's fine.
Cool. And thanks for pulling, responding to Matt's challenge quickly of
That was easy. That was not a challenge. I actually already had the Stanford thing up. I was going to put it earlier and decided not to. But yeah, fun.
Cool. Well, thank you much. Okay, and Helene, thank you so much for your quick work. I was a little nervous that if we lingered at all, Alan Carreau would start talking. So I was like, go, go, go.
Yeah, no problem.
But, anything on your side, any chats or anything on the IT side that went on?
No, everything was smooth.
Well, that's how we like it. And Twee, anything?
No, nothing for me. I'm just here as backup, and anytime I don't have to back up is a good sign. I do want to mention, Rebecca, since our office hours are canceled for Monday, I'm going to try and see if we can cancel that COVID meeting with Joanna on Monday mornings. So if we get that canceled, I'll let you know. Because it's at the same time as the Latin America one, and I really want to sit in on that Latin America one, just to see how the interpretation, Zoom interpretation works, and I've never experienced it. So.
And I'm actually on annual leave on Monday, so regardless.
Oh, that's right.
Okay. Not, I won't be there, so I'll be out hiking, but yeah, keep me posted on that. Cool. Okay, well, I hope everyone has a wonderful rest of your day and hopefully can run off and have fun this holiday weekend. Yay. And Helene, are you officially gone now after today?
Yes. So okay. This is the only thing I had to do today. So I was like, okay, well, guess I'll just chill at my house with the dogs.
Well, you need to milk it, girl.
I was like, so I was like, I'll turn in my computer at like 4:30, right? And they're like, yeah, it's fine. And I was like, Okay, well, I guess I'll just be here if you need backup on anything.
On call.
Yeah. Like,
When does
Hey,
school
take the day of being paid and not really doing anything, you know? I mean,
yeah, I'm babysitting my sister's dogs, and one of them is looking at me currently because I'm not paying enough attention to him. And I was so afraid that he was gonna start making noise. I was like, oh, please don't, because he's so loud. It's like those husky videos that you see. If you don't pay attention to them, it just really weird sounds that come out of him.
Oh. Yeah, I've heard that huskies can be a little needy.
And he's not even a husky. I don't even know what he is. He's a mutt of some sort, but he's just so vocal, and he's such a baby.
Aw.
well,
when
now
does
you get to
school
take
start?
care of him today, I guess.
Wait. I was like, what? There was two people that talked at the same time.
I was just asking when school starts.
The 13th.
Oh, okay. So you have a little bit of time off.